So we've talked about the wound parameters, and again, as part of a very systematic, comprehensive process, it is absolutely critical that you are addressing all of those wound parameters that we have discussed. That's going to be critical for developing your plan of care and helping you decide what type of wound topical therapies to use for your patient. One way that I like to think about wound management is, in the literature, there's actually an acronym called TIME. And these are some of the different elements, if you will, that you can think about as you are trying to determine an appropriate type of treatment for the wound. And by treatment, I'm really referring at this point specifically to topical therapies. So with TIME, TIME is tissue, inflammation, infection, moisture, and edges. So these are all some things that you are going to want to look at. And again, this is all part of the wound assessment that you've already been doing. And these are factors you want to consider when you are determining how you're going to treat that wound. The other thing that is very important is wound cleansing. There are a lot of questions about what is the best option for wound cleansing. Should we use saline? Should we use wound cleanser? What about peroxide or Hibiclens, soap and water, or are there other options? And again, this is really something that may be facility specific, but the standard of care really requires that the wound be cleansed at regular intervals with routine wound care and with an appropriate agent. So your best options are going to be normal saline as one. Normal saline is cheap, it's easy to get a hold of, it's physiologically compatible in the body, and it is certainly a very appropriate and effective go-to. Wound cleansers are also very appropriate, and wound cleansers are different than skin cleansers. Keep that in mind, because the wound cleanser is designed to treat the wound. A wound has a slightly acidic pH, and these are pH-balanced products, and they have surfactants in them. They have pH-compatible detergents that can get in there and kind of help clean up the wound. They usually have an extended shelf life so that you can use them multiple times on the same patient. And in some cases, they may have some additives in them, such as sodium hypochlorous, which can also help further clean the wound and help debride the wound. Hydrogen peroxide is really something that isn't appropriate for wound cleansing for a number of reasons. I think many clinicians now are aware that it's probably not one of the better options, but just to sort of reiterate that, hydrogen peroxide is what we call cytotoxic. It destroys the fibroblasts in the wound. And as you remember from the discussion about wound healing, the fibroblasts are those specialized cells that come in and deposit collagen and help with the promotion of granulation tissue. So we really want to avoid that. There's actually also been some anecdotal studies about hydrogen peroxide causing air emboli in some patients. So it's probably something that we really don't want to use if we can avoid it. Hibiclens. Hibiclens, or chlorhexidine gluconate, is a antimicrobial soap, and it is actually used quite often in some wound care centers. And it can be very helpful for intermittent use if you have a particularly purulent or grossly contaminated wound. For regular daily wound cleansing, it's probably not necessary, and in some cases you have to be very careful because Hibiclens can be a little bit irritating and can actually cause ulceration if it gets into the eye. So I would recommend avoiding that unless it's absolutely critical. Soap and water are sometimes used as a go-to when there is nothing else available. And that might be certainly okay in some extreme situations. I would again recommend avoiding soap and water because when we talk about soap, most soaps are very, very high in pH, so they're very alkaline. And wounds, as I mentioned, are on the slightly acidic side in terms of their pH balance. So if we are using soap and water to clean a wound, we are absolutely destroying the pH balance in that wound, and that can affect the ability of certain cellular players in that wound to work. It also can be certainly very, very difficult for that wound to bounce back and try to restore its normal integrity in order to try to continue to heal. And then certainly there are other options. There are some wonderful mechanical lavage devices, pulse lavage, and other products out there that can certainly be helpful. And if you happen to have that available in your facility, then I would definitely take advantage of that. But for our purposes, and I think for just general cleansing, really your two best options are going to be saline or wound cleansers. Now, as far as the time concept that I talked about just a moment ago, with time, the first concept is tissue management. So if you're looking at a wound, an important part of that wound management is looking at the tissue. You know, what are you going to do with that tissue in the wound? If there's necrotic tissue in the wound, the necrotic tissue really needs to be removed. And how you are going to do that is really going to be dependent on what you have available, how aggressive your treatment strategies are, how well the patient's able to tolerate that. But if at all possible, you want to try to remove the necrotic load from that wound. The reason for that is that necrotic tissue is like an all-you-can-eat salad bar for bacteria. It is a rich source of nutrition, and it will help to potentially perpetuate infection. It also will slow down the wound healing. A lot of times the wound is going to be difficult to get the wound to make progress until you get some of that necrotic load out of the wound. So removing necrotic tissue is very important. And then looking at trying to promote granulation. Those are the two main issues that you really want to look at in terms of tissue management. So, as I mentioned, debridement, that's removing necrotic tissue from the wound. And there are a variety of ways by which to accomplish debridement. Debridement is just a French word meaning to unbridle. It just means to remove that non-viable tissue to allow that wound to heal. And there's different ways to perform debridement in the wound. Enzymatic debridement is a very common option, and currently we have only one product on the market that is an enzymatic debriding agent. It is collagenase or Santal, and that's a proteolytic product that actually goes in, and it is specific to dissolving the protein bonds of the necrotic tissue to help liquidate that necrotic tissue and get it out of the wound. That is one form. That's enzymatic. Mechanical involves using usually a pulse lavage. It could be a wet to dry dressing, although we really do not recommend wet to dry dressings anymore. It could be a gentle scrubbing of the wound. There is a couple of wonderful products out there, one of which is called Debridement, that is actually a series of little monofilaments. It's a little monofilament pad that mechanically debrides wounds in a very non-traumatic way and works well. But it is a way of basically mechanically removing that necrotic tissue from the wound. Autolytic. If you are just doing good wound care with moist wound healing concepts, the wound will eventually autolyze. The body's own natural autolytic processes will take place, and it will eventually result in that necrotic tissue being removed from the wound. However, that can be a little bit more of a slow process. There is also excisional, and for some of us clinicians that are trained to do this, this would involve either surgical or sharp debridement using sterile instruments, scalpel, forceps, scissors, to really go in there and actually remove that tissue from the wound. That's probably one of the fastest ways to perform debridement, but it may not be practical in every setting. So here's an example, again, to show you the concept of debridement. We have a patient here who has a full thickness, unstageable pressure injury of the right heel. So undergoing debridement, this would be a situation in which he had a sharp debridement done, where, again, using sterile instruments, that cap of thick black eschar was removed, and now we have this open full thickness wound. But as we look at this, we can see that there is still a little bit of necrotic tissue. There's still some residual slough in that wound, and at this point it might be very appropriate then to use an enzymatic debriding agent or even moist wound healing to promote autolysis. So keep in mind that there are different forms of debridement, and that you can combine forms of debridement, or you may change your method of debridement depending on what's going on with the wound. But debridement is very, very important to get that that necrotic tissue out of the wound. The other reason as to why debridement is important too is it also helps to remove what we call biofilm. Many times with a chronic wound, there can be a development of biofilm in the wound, and that's a very, very important thing that can slow down wound healing. So debridement helps to eliminate or suppress biofilm formation. So now I'd like to go ahead and talk a little bit about infection. In terms of the time principle, we talked about time, T was tissue, I is infection or inflammation. Now, one of the questions that I always bring up to the audience is, can wounds heal if bacteria are present? And I always get a variety of different responses. And for the most part, really, anytime a wound has been open for any period of time, it is going to have bacteria in it. The bacteria are going to be present in the wound, and in some cases they may grow and colonize, and in some cases even develop an infection. But if a wound has bacteria in it, that will not prevent the wound from healing. So that is an important consideration to keep in mind. So the question comes up of what is wound infection? And when we talk about wound infection, probably a good way to look at it is it's really a continuum. Anytime we have a wound that's opened, as I mentioned, there are going to be bacteria present in the wound. And when that happens, we say that the wound is contaminated. It just means there are microorganisms that are present in the wound. They just happen to be there. They're not really doing anything. They just happen to be existing. Colonization refers to the fact that now we have the bacteria that are actively organizing. They've gotten into arrangements, and they are building communities, and they are actively colonizing the host. They're actively growing and living within that wound environment. Again, wounds that are contaminated and colonized can generally heal. However, as we move along that continuum, when we have critical colonization, that really refers to the fact that now you've got an excessive load, a very high bacterial load with many microbes present in the wound, and now there are so many of them that they are actively affecting the ability of that host to heal the wound. So that becomes very, very important. We need to make sure that we are managing wounds that we think are critically colonized. And then finally, infection. And with infection, that really represents the presence of colonized bacteria, and the gold standard is greater than 10 to the 6th per gram of tissue. And a lot of times with infection, not only do you have this excessive growth of microbes that may be very large in number and may be very virulent, but they also start to affect the condition of the wound and extend into the surrounding tissue. So as I mentioned, when we think about infection, it's really important to really think about a continuum of care. And I think knowing that should make us appreciate the fact that any wound is potentially has the ability to become infected at a given point in time. So managing the eye, managing the inflammation and infection in a wound are extremely important. So your clinical signs of infection. These typically will be things that we are pretty well versed in. Erythema or redness around the wound. Is there induration, as I mentioned, that firmness to gentle pressure? Is there pain? Is there all of a sudden more pain than there was before? That certainly may be an important factor. Is there fever? Is the patient running a low-grade temperature? Are you noticing any purulent exudate or drainage from the wound? Are there color changes? Do we have now the tissue was kind of a nice beefy red and now it's a little bit dusky? Or is there some odor in the wound? Those are some of the classic signs of infection that we will sometimes think about. And again, as part of your consistency in your wound assessment and as part of your tissue management, you always want to be looking for your clinical signs of infection. Other indications of infection in chronic wounds. You're doing appropriate care. You are noticing that the wound has been healing, but then all of a sudden it's just kind of hit a plateau. It's just not doing anything anymore. It's delayed healing. That may be a subtle indication in chronic wounds. As I mentioned before, discoloration or duskiness. Do you have tissue that was very healthy looking, but now it's a little more dusky, or you're starting to see a little bit more necrotic tissue in that wound? If there's granulation tissue in the wound, do you now see that it is very friable or gelatinous, or it bleeds easy with care? In some cases, you might even get something called hypergranulation, where you have an excessive amount or an abundance of granulation. And too much of a good thing is not always good. And when it comes to hypergranulation, that is something that you'll also need to try to address. Do you have unexpected pain or tenderness? In a situation where maybe the patient didn't have much pain, all of a sudden now it's a lot more painful than it was. It's a lot more tender. That is certainly a big red flag that you want to investigate. And do you have a sudden increase in the wound drainage? That's also a very big red flag that you want to take into consideration. So in terms of culturing a wound, there is certainly a field of thought that suggests that if you culture the wound, then you are going to have a good representative sample of what's actually in the wound that you can treat with specific antibiotics, which certainly makes very good sense. Some clinicians, if culturing is not readily available, or they see that the wound is actively infected or there's a lot of cellulitis, may decide to go ahead and treat that wound empirically with a broad-spectrum antibiotic. Certainly either option would be appropriate as long as we are addressing the infection. Now, if we should decide to culture, there are a number of ways by which to culture a wound. The gold standard is considered to be the biopsy, where an actual piece of the tissue specimen is collected and sent off. Other ways that we can culture a wound would include doing an aspiration of the wound fluid. Another way to do a wound culture would be what we refer to as the swab technique, and that's really what is most readily available to us. Now, that involves something that I will refer to as the Levine method of doing a wound culture. So in terms of moisture balance, we've talked about, again, the concepts of time, tissue, infection, and inflammation. Moisture balance is very important. Too much is not good, too little is not good. It's kind of like the Goldilocks principle. You want just the right amount of moisture in that environment. That is very, very critical. So if you have a very moist wound, then you are going to be looking at a topical therapy that will absorb that exudate and contain that exudate. If the wound is very dry, you may need to add a product that will donate moisture to the wound and keep that wound moist enough to promote wound healing. The important thing also is that if you have dead space in the wound, as we talked about before, sometimes you can have depth in the wound. You can also have undermining or tunneling in some cases. And as part of moist wound healing is the way to manage wounds. And maintaining moisture balance is to make sure that you're filling that dead space with an appropriate product. And the key is not to jam as much as you possibly can into that wound. You want to gently fill that dead space. It's not a competition to see how much of that Curlex roll you can get into that wound. It really is more of a matter of gently filling that wound so that you've basically got a moist environment or a moist dressing in contact with all surfaces of that wound to keep that tissue healthy and moist, to allow it to continue to granulate and proliferate. So for dry wounds, options that we have readily available would be your amorphous hydrogels. These would be your different types of hydrogel. These are clear viscous gel products. They may come in terms of a gel form, sometimes sheet forms. And these are very, very helpful in donating moisture to the wound environment. Foams are very helpful because they are moisture retentive and can also be used in combination with a hydrogel, for example, to provide a moist wound environment for that wound bed. In some select cases, you may decide to keep a dry wound dry. And in that case, you would use betadine, and this would really be the only indication where betadine would really be considered appropriate. And an example where that would be an appropriate thing to do would be, for example, a patient who has a questionable blood supply to their foot. They have some very dry eschar or dry necrotic tissue on their feet or on their heel. It is stable, and by stable it means there's no redness, no fluctuance, no indications of any infection, and you want to keep that dry. Then at that point, betadine would be an appropriate option. But for the most part, in the vast majority of your cases, you are going to want to keep add moisture to a dry wound, and again facilitate moisture balance. If the wound is wet, some of the products that can be very helpful are your calcium alginates, your hydrofiber dressings. These are products that are usually organically derived and can be placed into a wound or packed into a wound, and they have moisture wicking qualities. There are also some composite and polyethylene dressings that can be very helpful as well, that also serve to wick or pull moisture into the wound. There are some products that use even now what I refer to as diaper technology. The same type of material that is used in diapers can be used in some wounds to help, again, draw moisture and collect exudates. Foam dressings are also very appropriate to use in wet wounds, and they can be used in combination with calcium alginates or hydrofibers or even some composite dressings. So edges, so this is the E part of the time principle. We want to also really be critically evaluating the edges of the wound. As I mentioned before, you really want flat edges in order to help promote epithelialization. That final portion of that proliferative phase involves that cellular migration across that surface of the wound. So you've got to have flat edges for that to happen. So we really need to look at things to help promote that epithelialization. One thing would be making sure that the edges are flat, that we're debriding or managing any epibole. There are some products that we can use also that can be helpful for promoting that edge migration. Those would include sometimes collagen dressings, which are basically exogenous forms of protein. They may come from pig, sheep, cow, and even fish now. Negative pressure wound therapy is a very nice way, again, to help promote both granulation and to, again, encourage the advancement of the wound edges. And dermal skin substitutes. There are a variety of wonderful products that are out there that are either amniotic-based, cadaveric-based, or in some cases may be basically human foreskin that has been cultured and processed. But there are a variety of different dermal substitutes. And again, those are usually reserved for situations where the wound perhaps may be slow to heal and just may need some additional leverage to be able to move forward and finally close. Again, another example. This is epibole, or the rolled edges. A wound with rolled edges is not going to heal without some type of intervention, so addressing that is very, very important. So some of the other factors that affect wound healing. Infection. As I mentioned, a wound that is critically colonized or infected is not going to heal. So that has to be absolutely managed. One of the things that you will also hear is the concept of biofilm. I mentioned it briefly before, but a wound that is either critically colonized or infected usually will have a biofilm within that wound. And what the biofilm is really a situation where these bacteria have come together in a community and secreted all of these proteins, these glycoproteins. And what that has done, in effect, is allowed them to sort of secrete a protective coating over their colonies. And we call that a biofilm. And that biofilm makes it very difficult for topical therapies, topical antimicrobials or enzymes to be able to penetrate that biofilm. So we need to try to manage that. And again, part of our wound care decision making is really going to be looking at products that will help that. Your enzymatic agents, for example, can be very helpful with managing the biofilm in the wound. So we want to try to manage infection and critical colonization in that wound bed. Nutrition. Absolutely goes without saying, a patient who is malnourished is not going to heal, and a patient who does not get adequate nutrition when they have a wound are not going to heal either. And that's absolutely critical. This is where you really want to make sure that you are getting, working as part of a team approach, especially with your dietitian or your dietary consult, to make sure that the patient is getting adequate calories, adequate carbohydrates, fats, and proteins. And in particular, the proteins are very, very critical. And the recommended supplementation is about 1.5 grams of protein per kilogram of body weight. So that can be a significant amount of protein if you think about it. But this is where your dietitian becomes extremely important. And again, This may be a situation where the patient may benefit from some supplements, things like protein supplements, some of your products like your Benefiber, your Prostat, your Juven, your Arginate are all very helpful sources that just help to supplement that patient's nutrition to give them the building blocks that they need to be able to heal. So pressure, friction, and shear, those are also critical components that have to be addressed. And that's very, very important, because if pressure, friction, and shear are not reduced, a patient's wound is not going to heal. And in some cases, it will just allow that wound to get worse. So managing tissue loads, using good body mechanics, appropriate lift and turn sheets, appropriate surface supports are very, very important with these patients. Positioning and turning are absolutely critical. So managing pressure, friction, and shear, very, very critical for wound healing. Perfusion and oxygenation. Again, we may not have a whole lot of control over that, but I think being aware that a patient who does have perfusion issues, a patient who has known peripheral vascular disease or diabetes with microvascular disease, may not have the ideal perfusion, and that certainly is going to impede their ability to heal. And so even though we may not, as a clinician or as a nurse at the bedside, for example, you may not be able to control that, I think being aware that that is a risk factor is very important, because that may require that the patient will need some additional studies perhaps to evaluate the extent of their circulation issues. And in some cases that might require then a referral to a vascular specialist or other specialist who can address that. So perfusion is very, very important. If you don't have any flow, the tissue ain't going to grow. So it's very important to keep that in mind. Glycemic control, and I think probably most clinicians really recognize the importance of good glycemic control, particularly with our diabetic patients. One of the things that we see sometimes in patients who are not well controlled is something called a hyperglycemia-induced leukocyte dysfunction. In other words, elevated blood sugars over time will affect the ability of the white cells to work. And as you know, the white cells are very important players in terms of facilitating the development of new tissue, especially granulation tissue. So that's very important. Also, patients with diabetes are going to be very, very susceptible to infections. And it's going to be very, very difficult to treat their wounds if they are having infections repeatedly. So the glycemic control is very important. And also just to help prevent a lot of the different microvascular complications that can occur in diabetics over time. So managing the diabetes is extremely important. And moisture incontinence. And I'm sure none of your patients are incontinent. It's a huge problem that we deal with, especially if we're dealing with wounds that are in the lower pelvic or sacral areas. So managing the moisture and incontinence are very important. In some cases, it may require a toileting program for that patient. It may require the regular and religious use of moisture barriers for the patient who's incontinent after each episode and prophylactically. In some severe cases, if the wound is really significant, there may be a necessity for a short-term use of a Foley catheter. That has to be done very judiciously, but that certainly may be another way to maintain that moisture incontinence. Making sure that the skin folds are kept clean and dry so that there is not the development of intertrigo. That can certainly complicate a wound or can in and of itself lead to more problems with wounds and wound healing. Stress. It's very interesting. There is a lot of research really dating back to the early 2000s that stress can definitely affect the ability of someone to heal. Someone who is under a lot of physiologic or psychological stress will be pouring out a lot of catecholamines and other types of adrenal hormones into the system, particularly cortisol. And that will definitely affect the inflammatory response. And as you know, a wound has to go through an inflammatory period to be able to heal. So stress can be very detrimental to wound healing. And medications. There are a variety of medications that have the ability to impact a patient's ability to heal. Steroids are notorious because, again, they will impact the inflammatory process and, again, discourage that wound from being able to heal. Patients who are on anticoagulants may have difficulty with achieving adequate hemostasis. Patients that are on immunosuppressive drugs also will have difficulty trying to get through an inflammatory phase of wound healing. Patients that are having problems with malnourishment and are taking supplements may also be at risk. So there are a variety of different medications that can ultimately have a negative effect. And certainly, while we may not be able to eliminate all of those medications, it's important for us to be aware of them and keep that in mind as we develop a plan of care for that patient. And there may be some other things. Again, things that will also factor in will be the patient's psychological status, as I mentioned, their willingness to participate in a plan of care, their willingness to go along with what you need to do to help them. That will be very, very critical. Having the supports that you need, having a team to work with, having the facility and the resources such as the support service if the patient has a pressure injury. So all of those things collectively are important to consider, especially when you're looking at what can affect your ability to help that patient heal. Pain also is very important, and I think sometimes we don't always think about that. We sometimes give that a second thought. But it's very important to assess pain at regular intervals, and if the patient does have a lot of pain with the wound dressing changes, it's important to make sure that they're being pre-medicated as needed. And as I mentioned before, if there's a sudden increase in pain, you really need to investigate that and try to determine what it is that's causing that pain. Is it a problem that may just be relieved with simple positioning? Do you have an infection occurring? Are they laying on something that's causing an issue for them? So any type of sudden increase in pain, investigate that thoroughly. So as I mentioned, it's absolutely critical to thoroughly investigate any and all sources of pain so that you can intervene appropriately. Thank you.